Bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, and the McMaster Children's Hospital Foundation. We would also like to thank the following Keystone Partners for their ongoing contributions that support all of CAPHC's programs and activities. All right, hello everyone, and welcome to today's episode of CAPHC Presents. My name is Doug Maynard, and I'm the Associate Director at CAPHC, the Canadian Association of Pediatric Health Centres. Today's webinar is titled Lessons Learned from Screening for FASD in the Youth Justice Offender Population. So it's my pleasure to introduce a number of colleagues that will almost be certainly familiar to our audience as we continue our discussions on the development of screening tools for fetal alcohol spectrum disorder. This is part of our ongoing work and partnership with the Public Health Agency of Canada. The topic today is related to our screening tool that is specifically focused on children and youth in the youth justice system. And you may recall some of our previous webinars on this topic, all of which are posted on the Knowledge Exchange Network. I think we have at least two and maybe even three that have that that are focused on that topic. But again, if you search for youth justice on the Knowledge Exchange Network, that's you'll be able to find them. Before I introduce our speakers, though, I would like to recognize one specific individual who's been part of this work for many years and her amazing and tireless efforts. Our project manager, who has continuously cracked the whip behind the scenes to make sure we stayed on track throughout this project. It is now into this project started before I got here, so I think it's in its 6th year or maybe even a little bit more. Charlotte Rosenbaum, who has been part of this work since the beginning, has been threatening to retire for the last little while, and she's finally made good on that threat, and she let me know that this may be the last webinar that she's going to be part of. Not as a presenter, but always behind the scenes helping coordinate not just the webinars, but all of the work that has led to the development of the screening toolkit and everything that CAPHC has done related to FASD screening tools. She has really been the lead on all of that. So I know I speak on behalf of CAPHC and our FASD screening tools steering committee when I say thank you, Charlotte, for everything that you've done in supporting this work, and we wish you well in your retirement. So it's my pleasure to welcome back Dr. Ab Chudley, who's currently the Medical Director of the Genetics and Metabolism Program with the Winnipeg Regional Health Authority and Professor in the Department of Pediatrics and Child Health and the Department of Biochemistry and Medical Genetics at the University of Manitoba. He is an expert, I think, on all things related to fetal alcohol syndrome and fetal alcohol spectrum disorder, and certainly no stranger to CAPHC's, the CAPHC Presents audience, particularly our FASD presentations, as he's been part of, I don't even know how many now, but many. So I'll hand the virtual podium over to Dr. Ab Chudley to introduce the rest of our panel. Over to you, Dr. Chudley.
Well, thank you, Doug, and it's a pleasure to be back to the webinar and to do a follow-up on the studies that have been done through the Youth Justice Screening Tool project and using the Asante tool. My job really is to introduce the main speaker and my colleague Teresa Brown, who participated in the study. Dr. Deepa Singhal is a PhD candidate in the Department of Community Health Sciences at the University of Manitoba, and her research is focusing on FASD health issues. And she's been involved with our project and evaluating the Asante tool for the last two years plus. And so we're delighted to be able to show you some of the results of these studies and make comments on next steps and some of the challenges and some recommendations we've made out of the study. So Deepa is going to be providing the information, followed by questions. And so Deepa, myself, and Teresa Brown, who is the manager of the FASD Youth Justice Program and in the Manitoba Youth Center, where the diagnostics occur and where the youth come after they've been charged and brought in. So We look forward to having lots of questions from the audience. Hopefully this will be quite interactive. The talk's going to be about 20-25 minutes at most, so we hope to engage the audience. So without any further ado, I'm going to ask Deepa to take my seat, and we'll begin the presentation. Deepa.
Hi, everyone. Good morning. I'd like to thank our audience for participating in our presentations. As was mentioned before, we have done some previous webinars which are on the website, and I will refer to them when appropriate during our talk today. I'd like to acknowledge Dr. Chudley and Teresa Brown, who have done an outstanding job implementing this program in the community, as well as the staff at the Justice Center that participated, the probation officers, our funding from the Public Health Agency of Canada, and Dr. Trevor Markison, who initiated this research. So as we know, research has shown that a substantial proportion of youth are diagnosed with FASD are involved in the justice system. And the goal of the youth justice system is to rehabilitate, prevent, or reduce criminal offenses in the future. And thus the Youth Criminal Justice Act stipulates that special considerations should be made for young offenders with special needs, including FASD. Therefore, identifying youth with FASD who are involved with the justice system is the first step to ensuring fair treatment and consideration for sentencing and rehabilitation. So there's a need for an action-oriented response to deal with the identification, sentencing, management, and rehabilitation of adults and youth with the FASD in the criminal justice system. And by accurately screening for youth, this will ultimately increase the well-being of this youth by facilitating access to a full diagnostic assessment. And this, again, will increase the fairness and appropriateness of sentencing and facilitate tailored rehabilitation and treatment. So the purpose of screening is to identify individuals who are likely to have FASD, and that will facilitate them going to a program where a full diagnostic assessment can follow. And an effective screening tool is generally easily administered and user-friendly and cost-effective. And effective screening tools demonstrate high sensitivity and specificity. So what is sensitivity and specificity? Well, those are terms that epidemiologists like to use to describe tools. And so sensitivity is the ability of a tool to correctly identify people with the condition who screen positive. So this is the true positives that result from a screening test. And specificity is the ability to correctly identify persons without the condition within a population who screen negative using the screening tool. So this is identifying true negatives. And higher sensitivity and specificity indicate greater accuracy of tests or tools. In order to calculate sensitivity and specificity statistics, we need a reference standard in which we compare our calculations to. And a reference standard is an alternate method to determine the condition among individuals with a positive test. Currently, the standard isn't available for FASD screening in the justice system other than a full diagnostic assessment. So, and also currently there are no validated screening tools for identifying FASD in young offenders in Canada. The Asante Center in British Columbia developed the Asante screening tool for probation officers to screen for youth with possible FASD. And I believe they did a little bit of validation within their own center. And this screening tool aids youth probation officers to recognize youth offenders with possible FASD, and it's designed to increase the capacity and confidence of probation officers, hopefully across Canada, to identify youth requiring full FASD assessments. The Canadian Association of Pediatric Health Centers has endorsed the use of this tool and has included it in their national screening toolkit. So the tool is a pre-coded questionnaire that collects information on the social and neurodevelopmental history of the youth, as well as probation officers' knowledge of the youth and FASD. And the tool consists of a series of short questions categorized into social factors and personal factors of the youth. And this is a snapshot of the social factors. The full tool is available on the Asante Center website, which I've referenced in this slide. The social factors include if the youth has been adopted, if the youth has been in foster care, if the youth has been involved with Child Protective Services, and if the youth has a sibling with FASD, and if there is documentation that the youth is suspected of having an FASD diagnosis, and if the youth's mother has a history of alcoholism or known prenatal alcohol use. The personal factors include questions about developmental delays, school learning difficulties, growth deficiency, diagnosis of ADHD or ADD, and any other mental health diagnoses. So referrals are made based on the combination of either one social or environmental factor plus two personal factors, or no environmental and social factors, but at least three personal factors. So the screen requires the probation officer to fill out the two previous sections, and then using this criteria to determine if the youth meets criteria to be referred for a full FASD assessment. So here in Manitoba, the Manitoba FASD Youth Justice Program was implemented in Manitoba Youth Corrections in 2004. And this program addresses the complicated needs of young offenders with FASD in the Manitoba area. And the primary goals of this program were to assess youth who are involved in the justice system who may have FASD, to provide recommendations to the court, and to build capacity within families and the community while enhancing government and non-government FASD supports and services, and to implement multidisciplinary interventions and reintegration plans with supports for youth affected by FASD and their families. So the program currently uses a behavior-based approach to screen for kids or youth with FASD, and called the red flag method. So the youth is referred to the FASD program if the youth exhibits behaviors that are consistent with FASD. And these can include failure to comply, a lack of empathy, trouble in school, difficulties with intuition, difficulties with peer interactions, the inability to connect actions with consequences. The youth doesn't seem affected by past punishments. They engage in crimes involving risky behavior for very little gain, and it often involves gang involvement. And here's a list of some of the red flags that the staff look out for. They look out for behavior problems, attention problems, signs of impulsivity, learning disabilities, growth deficiency, and particular relevance to this population, again, trouble understanding consequences of their behavior and crimes, and trouble with empathy and sympathy of victims. So this diagram depicts how it all kind of comes together and how the red flag method aids in the assessment of youth with possible FASD. So on the left-hand side, you see some of the red flag categories. So staff refer youth who they suspect are at risk for FASD by watching out for these red flags and by identifying behaviors that are consistent with FASD. And then they refer these youth to the FASD program. The FASD program coordinators further investigate the alcohol history and prenatal alcohol use of the moms and the medical histories. They engage with the families to obtain this information and to confirm prenatal alcohol use. If prenatal alcohol use is confirmed, the youth are then referred to the FASD diagnostic team for a full diagnostic assessment. So although this approach has been successful in referring a large number of youth who may have FASD, from an academic and a research perspective, it's not a systematic approach that has consistent documented criteria in referring the youth for the FASD assessment. So youth may possibly be missed using this method. And furthermore, in the past, probation officers may not have had consistent training regarding the red flag method, as there were no mandatory training sessions for new or existing probation officers. All youth and adult institutional staff receive mandatory one-day FASD training during this basic training, and probation officers may have participated in this training, but we're not sure if all of them have or haven't. And the youth institutional staff receive an additional FASD, a 3-day FASD training. But again, we're not sure if the probation officers were involved in this previous training. Plans are currently being made to train probation officers in 2014. So the purpose of our research was to assess the validity and applicability of the Asante tool in accurately identifying young offenders at risk for FASD in Manitoba, and to apply epidemiologic research methods to compare the red flag with the Asante tool. So the goals of our research were to critically evaluate the applicability of the Asante tool, to evaluate the sensitivity and specificity of the Asante screening tool against the red flag method, and to generate practical recommendations regarding the possible implementation of the Asante tool in Manitoba, and to highlight possible barriers to implementation, as well as staff perceptions of the tool. So our evaluation project consisted of 2 studies. Part 1 was a retrospective chart review, which is completed, and Part 2 is the prospective study, which is almost completed. There's one portion left to still do, which I'll touch on when I get to the results. But the details of the methodology of these studies were presented in our last webinars, and these presentations are available on the CAPHC website. So I'd like to focus the remainder of this talk on the findings and the recommendations of both of the studies. So we conducted a retrospective chart review of over 300 charts, 323 charts to be exact, to assess the sensitivity and specificity of the screening tool compared to the red flag method, who were on youth who were admitted to the Manitoba Youth Corrections in 2006 to 2009. And what this retrospective study showed was the red flag method and the Asante screen referred different youth to be at risk for FASD when we looked at the youth charts. And there wasn't a high rate of overlap of youth who screened positive by both tools. So the Asante tool may be missing youth who screen positive by the red flag method, and the red flag method may be missing tools who screen positive by the Asante tool. And this is a very important finding that will have implications on implementation. So the Asante tool is more comparable to the red flag method when screening out youth who are not at risk for possible FASD, which means the tool is more specific than sensitive when comparing it to the red flag method. We also found that there was a high proportion of missing information in existing youth charts that prohibited definite conclusions regarding the Asante tool being used in Manitoba, and that led to a recommendation of a prospective study. So because there was a high proportion of missing information in youth charts where we couldn't use the Asante tool fully to reach a recommendation if the youth should be screened or should be referred for further diagnostic assessment, our key recommendation was that a prospective study should be conducted that prospectively in real life compares the red flag method to the Asante tool before recommending that this tool be implemented in the justice system. And so what we wanted this study to do was to have the probation officers actually fill out the Asante tool using the information that they would have on a day-to-day basis to see if they would actually have the information required by the Asante tool. Because some of the charts, the information may not be recorded, but the probation officers may have it. So we decided to proceed with a prospective study. We also recommended that the Asante tool should only be used by probation officers on youth where they have a reasonable information or a reasonable relationship with the youth. Otherwise, this information would be too difficult to collect. So the objective of Part 2 was to prospectively compare the red flag screening method utilized at Manitoba Youth Corrections to the Asante tool, and to receive constructive feedback regarding the ease and effectiveness of the Asante tool from probation officers. And this was done using a survey component at the end of the study that probation officers filled out about the red flag and the Asante tool. So we recruited 21 probation officers across the 4 sites in Manitoba, and we assigned 10 of them to be to the red flag group and 10 of them to use the Asante tool. We had a few dropouts due to retirement and time issues and position changes. We ended up with 8 study participants in the red flag group and 9 probation officers in the Asante tool group. During a 6-month data collection period, we had 59 youth give their consent to participate in the study, and 35 of these youth screened positive for FASD. 7 of these referrals were made from probation officers using the red flag method, and 27 of those referrals were made by probation officers using the Asante tool. And so what we're doing now that we have the referrals from the probation officers is that we are doing full diagnostic assessments to determine the relative predictability of each of these tools, and this analysis is ongoing. So we don't have sensitivity and specificity statistics to date, but that will those results are forthcoming once the assessments will be done. So this prospective study did demonstrate that the Asante tool generated more referrals to the program versus the red flag method. And the survey feedback from the probation officers, the majority of probation officers who used the red flag method did agree that they were familiar with this method, that they were confident in using the method to refer youth with possible FASD for further assessment, and that they have used the red flag to refer youth with potential FASD. The majority of the probation officers were neutral as to the effectiveness of the red flag method, and there's no clear agreement or consensus on the other aspects of the survey. The opinions were split on whether they needed more FASD training to use the red flag method, and that if they wanted a new tool to be implemented. The majority of probation officers using the Asante tool agreed that the tool was user-friendly and that they had enough information on the youth to fill it out effectively, that it could be filled out in less than 20 minutes, and that it was an effective screening tool. But they, again, were neutral when asked if they would prefer to use this tool compared to the red flag method, and if they referred more youth for assessment using this tool than they usually do using the red flag method. So we recommend that further discussion needs to be done with the we recommend that further exploration with probation officers needs to be done as to why they were neutral about the Asante tool's ability to refer more youth versus the red flag method. So we're going to hopefully have a session with the probation officers to discuss the study results and place them into some context. We know that in research like this has shown in the past that implementing a new tool, possible issues of workload increases can be a barrier to implementation of a new tool, and these issues need to be considered if this tool is to be implemented in Manitoba. So the key findings, again, the prospective study demonstrates the Asante tool generates more referrals to the FASD program than the red flag method. So this may be possibly due to an increased awareness of FASD symptoms when the tool is actually being used on every single child that comes into the caseload of the probation officer. So it may just be a virtue of exposure. Results from the retrospective and prospective study demonstrate that the 2 screening methods identify different youth for possible FASD. And this is an extremely important finding. The Asante tool focuses on social environmental factors, while the red flag method focuses on behavioral factors. So they may be capturing 2 different populations of youth. And this is really, really important when implementing this tool in Manitoba, because we don't want to start missing the youth that the red flag method picks up if we implement the Asante tool. Again, to recap, there was inconsistent survey findings regarding probation officers' need for further training, and the extent of previous training wasn't known by this survey. We recommend a need for consistent mandatory training sessions for all probation officers for FASD knowledge, to increase their awareness of FASD, as well as for whichever screening method gets implemented, there needs to be regular training sessions held to ensure that probation officers know how to use the screening method effectively. There was inconsistent responses on the confidence and effectiveness of the red flag method. Half of the probation officers indicated they would prefer a standardized data form, and half of them indicated that they wouldn't. So again, we want to have a session with the probation officers and get their feedback on this. The probation officers who used the Asante tool stated that it was user-friendly and could be filled out in a timely manner. But again, there was inconsistencies when actually asking them if they wanted the Asante tool implemented in Manitoba. So our recommendations, we recommend that the Asante tool be implemented with the integration of the red flag method to ensure the youth at risk are not being missed. Ultimately, implementation is administrative decision, but this is what we think at the moment. In jurisdictions where there are no screening methods in place, the Asante tool is an effective screening tool. It does pick up youth, and if those other jurisdictions are similar to the program in Manitoba, probation officers should have enough information to fill the tool out. We do recommend that the Asante tool is used only by probation officers the way it's structured at the moment, but it can be adapted for other staff in Manitoba and possibly in other jurisdictions, but further work needs to be done regarding the adaptation of the tool, depending on essentially what information is available to that staff about the use. The Asante tool may ask for detailed information that's not available if the staff or the probation officer doesn't have a relationship with that youth. Oops, sorry about that. And as we said, there needs to be further consultation with probation officers to address issues as workload and time issues. And the recommendation that consistent training regarding the identification of youth needs to be implemented. So what were our lessons? Well, there were lots of them. Our major lesson and kind of piece of advice to people who are taking on a project like this in other jurisdictions is that research with the justice community should take on a community participatory-based approach. Stakeholder buy-in is very necessary when evaluating existing screening methods or implementing new screening tools for identifying FASD in the youth offender population. Buy-in from the frontline staff is imperative, especially if the implementation of the tool is planned. So the stakeholders that were involved in this study included the judges that we sought approval from, physicians in the Manitoba FASD Center, program staff, probation officers, and myself, a researcher from the university. So we all brought in our expertise, our prerogatives, our perspectives to plan this study and to implement this study so that we could do a fair and unbiased evaluation of the existing method of screening and a possible new method of screening. And this increased the quality of our study. Involving Teresa Brown really gave us a vehicle to have good relationships with the probation officers to ensure that we would get less attrition and accurate results in a timely fashion. The ethical issues of doing research such as this in the sensitive population needs to be addressed, and time needs to be implemented when doing this in other jurisdictions. We cannot stress this enough. Ethics need to be sought from the University Ethics Research Board and the judicial system, and this can often be a timely process. So factor this in if you're going to do this kind of research in your jurisdiction. The capacity of the system must also be taken into account when implementing screening for young offenders. Screening is only ethical and effective if the community has the capacity to offer these useful diagnostic assessments. So it's great if you're going to go and screen large numbers of youth and say all of these youth require full diagnostic assessments, but if you don't have the capacity to diagnose these youth, that needs to be considered. And the Manitoba FASD program is an excellent example of a cost-effective model that uses existing resources in the community to screen and facilitate diagnosis of FASD among young offenders. And it's an excellent model to implement in other jurisdictions that are looking to facilitate these full diagnostic assessments. And Dr. Chudley and Teresa can touch a little bit about this if people have questions about where to get kind of guidance to implement these resources in their own jurisdiction. So the major challenges of our research: time. Nobody has it. Everyone is extremely busy. All the parties that were involved in this research project are extremely busy, so make sure you plan for this. The research project always goes over what you planned, so plan for additional months. The ethics issues, where you're dealing with a vulnerable community, there's sensitivity issues, consent issues, approvals need to be sought from multiple parties, the youth, the probation officers, court approvals, the university. Also, there are scarce resources available in the justice system. As many of you know and can relate with, it's a stretched out system for time. So researchers out there that are doing planning on doing research in the system, you have to acknowledge that people who are dedicating their time are doing so out of their passion to increase the well-being of the youth that are involved in the justice system. They've got busy lives, and often research isn't a priority. So good communication, setting timelines, sticking to your deadlines, and acknowledging that people are tight on time is really important. As well as understanding different perspectives. Researchers, physicians, program staff, probation officers, frontline staff often come at problems and projects with different mindsets, and so to be mindful of language. Researchers often have, I can say this, sometimes use blunter adjectives that may not, and they don't intend to offend the existing policies and existing systems that are in place. So researchers, be mindful when you use words like systematic and effective. We use them very lackadaisically, but the red flag method is a very effective method that's been used for the last several years. It has generated over 700 referrals to the program. So, when evaluating an existing method like that, you need to be mindful and respectful of the fact that that has been an effective program. And bringing in the Asante tool can only enhance the screening that's already being done in the center. And so this should be something that researchers take into consideration for future jurisdictions. I think I'm going to end there. So we know that the Asante tool can enhance the capacities of probation officers to more systematically screen for FASD. And ultimately, this will increase the well-being of young offenders afflicted with FASD by increasing the fairness and appropriateness of their sentences and tailoring rehabilitation and treatment. I think that's a good place to end.
Thank you, Deepa, for a nice, clear presentation and summary of some of the conclusions we've had. I'm just going to I'll hand it over to Doug for questions, if there are any questions, and then we could also have some comments from Teresa, if that's the case.
All right, sounds good. Yeah, we did have quite a few questions come in. We have the first question that came in is from a parent of a child who is now, it sounds like, is now an adult with FASD, and she thought you mentioned, Deepa, earlier on in your presentation that it is actually required that accommodations be made for youth in the justice system once they are diagnosed with FASD. And she says that she has certainly seen how helpful that was for her son when he was in the youth center. Something she wonders is whether this is also true in the adult justice system, or whether this is something we await. I think she means that there's going to be issues that she needs to be prepared for in the adult system that doesn't make similar accommodations. And she says she goes on to she says, I mean, now that he is an adult, if he is involved again with the justice system, will there be awareness or accommodation of his disability?
That's a great question.
That is an excellent question. And as Deepa had mentioned, it's Teresa here. Deepa had mentioned that all adult correction staff, the institution staff, they receive a one-day, like the FASD training, so they certainly have an awareness. I think communication is key, even from the parent, having that communication, passing that information along so that people working with the adults have that information, also sharing the information with the court so that they are aware of that information so that any accommodations can be made for the adults. The communication is key.
All right, thanks, Teresa. We had a few questions come in from Richard out in Vancouver. He said a few questions and comments. He says he likes the red flags system that you use. He said just some food for thought, just based on what sounds like years of his experience in this field. He says the red flags, the informal red flags that he often uses are, is the client forgetful? Is the person impulsive? And does the person exhibit behaviors that need to be reframed? He suggests that he's maybe been wrong once in all of his assessments after the diagnosis has been actually made.
I missed the end part. Could you repeat the end part, please?
Yeah, he's just suggesting that he likes the red flag system. He finds them to be very accurate, and that he used similar red flags informally, but his were more general around, is the client forgetful, is the person impulsive, and does the person exhibit behaviors that need to be reframed. He finds that he's been quite accurate in his informal assessments that he's been able to confirm following diagnosis later on.
You know what? We agree. We think that the red flag method is a great method to use, and I think the purpose of the Asante tool is just to enhance this and to be able to systematically track and systematically refer. So I think when implementing this tool in Manitoba, we do want a combination. I mean, the red flag method is accurate, but we don't know how many youth could possibly be misusing the red flag method, and implementing a screening tool, whether it be the Asante tool or not, or like a screen, would ensure that all youth get the screen, as opposed to maybe the red flag method is being implemented by probation officers who have a vested interest in FASD or know more about it. So while it is effective, we don't know how many people it's missing. So that's the purpose of this research, was to say, well, maybe we can implement a systematic screen that all probation officers need to use on all children who are eligible for the screen.
All right. He went on to comment, I think you were on your slides, around the sort of the lessons learned piece when you were talking about the time and workload issues and that sort of thing. And he suggests that he doesn't really find the workload issues and the time issues to be that big of a deal. He says these referrals are similar to making other client referrals, and perhaps even less time consuming. He goes on to suggest that the sensitive issues are often overcome by using, the right language and the right words in a compassionate way. And he also goes on to suggest that even if resources, in the end, if a diagnosis is made but resources are not available, he suggests even if those resources are not available, better life circle outcomes are one of the results of knowing that at least that a person is suspected of having FASD.
Mm-hmm. Those are good comments. Thank you. It is having that awareness and maybe making some accommodations without having the full diagnostic assessment.
I like the idea of merging the behavioral component with some of the social and personal factors that are the core of the Asante tool. And I think we've shown or alluded to in the research that the Asante tool is good at screening out kids, but it may be missing a lot more. And we may be identifying more kids through the red flag method. And I'm not so sure the sensitivity is as high, although the red flag method is two steps. One is the frontline worker saying, we think this kid may be FASD, and then our youth justice coordinators dig deeper and get the social and medical. So it's a combination of things that enhances the likelihood of a higher sensitivity and specificity. So when they do come in for a diagnosis, and we've had, Teresa, 220 kids in that range, we have a 70% diagnostic rate. So that's a fairly decent sensitivity, identifying those that are likely affected who've been screened. We don't know, well, that's a fairly good specificity. We don't know the sensitivity.
Yeah, and I think that might be, a good opportunity to sort of mention. I think we mention this every time we have one of these webinars. Is that these tools are about screening and not about diagnosis.
Not a diagnosis, right?
Yeah.
But the screen tool has to be linked to diagnosis, and that's how you get sensitivity and specificity rates.
Mm-hmm.
And in order to do a study that will be accurate and reliable to confirm the sensitivity specificity is very, very expensive. So you have to take all kids coming in and do diagnostic assessments on them, and then look at the scores on the screening tool, and then look at the results of a diagnostic assessment. But that is several hundreds of thousands of dollars. So it's not practical, actually, and that kind of research is not easily funded. So we've had to take the other route. And of course, that's true for the Asante tool. Speaking to Dr. Julianne Connery, who's one of the co-authors on that tool, she made it great attempts to do further validation and accuracy assessments, but that wasn't funded because of the cost. So I think the study that we've done helps, I think, promote the utility of this tool, but also identify some of the concerns and how maybe a merger of the two methods may enhance the sensitivity and specificity.
But the tool undoubtedly increases awareness. And just having the virtue of having a tool, highlights to probation officers, does this child or doesn't this child? It brings it to the forefront of their consciousness.
And as Richard had commented earlier, that in his questions and comments, he had mentioned that making those accommodations and having that awareness, if you're suspecting and you're really looking at, is this behavior only, or could this be a result of maybe possibly an FASD?
All right, our next question came in from Beth Ann, and she says, hi, and thanks for the great presentation. She was wondering how long the N of 9 probation officers who use the Asante tool, how long did they get with an orientation to the use of the tool?
It was basically a one day over a lunch hour. They were all kind of aware of FASD, and then we walked them through the tool, gave them the booklet, gave them the information, answered any questions they had. We then followed up with them for several meetings individually if they had questions, and quite a few probation officers, we had one-to-one visits with them to show them how to fill the tool out on kids in their existing caseload. So we did have a lot of one-on-one interaction after that initial training session.
Beth Ann sort of goes on. She put this comment in before. We've had a few more comments from our panelists here about the sort of the blending of the various pros of the different tools. So this comment came in before that, but she certainly is supporting that concept of perhaps blending of the two tools. She's wondering, since the Asante tool seems more sensitive, would it be possible to augment it slightly with the major behavioral indicators from the red flag and thereby capture the best of both?
Was that a question, Doug? Sorry, or just a comment?
It seems more of a comment based on in sort of looking back, since you've sort of mentioned this already, but her question came in before you made that comment. But
yeah, I'm happy she agrees with us.
Yes, great. Well, it's great to know that there's so much interest out there.
Mm-hmm. That's all the questions that we have now in the hopper so far. Not sure if there's any other comments from the panel while we give people maybe some last few minutes to type in some last questions.
Are there any people out there who are looking to implement tools in their own jurisdictions? Do we have anyone out there that wants to give their comments on that?
Yeah, if anyone is interested in that, just type into the question box if you are, and we can get that information out to the to our panelists.
And while we're waiting for questions, I just wanted to also echo your very complimentary comments about Charlotte Rosenbaum's role in the screening toolkit, the steering committee, and the research that's been done on all the different tools, and her dedication and expertise is so much appreciated. And apparently she feels she has to retire, but she was really a great resource to the steering committee members and kept our research on track. So I want to also echo and congratulate Charlotte. We're very sorry to see that she's leaving the program, but says that she's still available to consult. So it's been a real pleasure working with Charlotte. Of course, Elaine, who's joined us as a panelist, was the brains behind all of this, and it's been a real pleasure working with CAPHC over the last I don't know, is it 7 years now, Elaine, or 8 years?
It has been 7 wonderful years, Ab.
Yes, well, it's and you know, we're looking forward to new research ideas, and I think this study has generated some potential research ideas that need to be moved forward. But again, thank you for your role and dedication to this endeavor for our children, Elaine.
Ab, that's very kind, and I really need to turn that back. This has been, and really for everybody listening today, this has been an incredible model of national collaboration that has brought together an interprofessional group, a very large group and network of content experts, families, again, that interprofessional component, which is so important and so relevant to fetal alcohol spectrum disorder. So I really think that's really what needs to be recognized as which has really enabled our ability to achieve what we have over the last many years. I don't think our work is done yet, and you've just sort of implied that, Dr. Chudley, and I think that what we really need to think about, and some of the comments that have been made just in the last 30 minutes or so, I think are pointing at continued work that has to be done. And maybe as a next step for our youth probation officer tool, we need to be looking at that blended concept that we're talking about, because maybe that's an even stronger answer or brings greater strength to the tool itself.
And I also want to acknowledge that the work of this research has really been in the hands of Deepa and Teresa. Yeah. Without their involvement, we would not have any study to be reporting on. And so it's not just at the national level, but at a local level where some of the research is ongoing. It's built up partnerships and enhanced multidisciplinary approach to research in FASD. So I want to acknowledge them for their valued input and the essential roles that they played.
Absolutely.
All right. Well, it sounds like we had a couple of comments did come in while we were chatting there, and Beth Ann has said she's very interested in discussing these findings with her collaborators. So I'll put her in touch with you, Deepa. She's a researcher and evaluator, so that'll be a good connection. And we also had a comment from Tracy, an FASD coordinator with the new Nunatsiavut government. She said she's not sure what the local justice view is on FASD now, but she's hoping to meet with some of the probation officers, and she's definitely going to use this as a resource to talk to them about it. So,
well, that's great.
Wonderful. Great.
all right. Well, I think that's all we have, unless there's any final closing comments from our panel, or.
No, but thank you, Doug, for your excellent coordination efforts and having these webinars go as smoothly as they do. Without your expertise there, people wouldn't be able to hear us. It's a wonderful resource with CAPHC, the CAN Knowledge Exchange Network. So congratulations.
Well, thank you very much. Thank you.
And I can just suggest maybe before we give the last word to Doug is stay tuned. There's lots more very important work, and that will be supported by our continued collaboration. And that collaboration needs to engage many of you that are on the webinar today. And so the work is not done, and we will continue to stay very closely connected to our FASD community.
All right. Well, thank you to our audience as well for joining us. We love having you and the questions. It really adds to the presentation to have the live question and answer and really enhance the discussion. So thank you to our audience. And of course, thank you to our speakers, Dr. Chudley, Teresa, and Deepa. And we do typically do these webinars on Wednesdays at 11 a.m. Eastern Time. So you can always check the website, caphc.org, for more information. We call our webinar program CAPHC Presents. So you can always click the CAPHC Presents link and see a calendar of upcoming events. We do have a few more FASD-focused ones coming up on defining the rate of heavy fetal alcohol exposure in Canada, which is going to look at the MyREX study and the use of meconium screening to identify the rate of heavy alcohol exposure. We have a number of other FASD from our FASD series as well. Validation of the Canadian developed screening test for behavioral phenotype on May 14th, as well as others. So go to the website if you need more information, and we look forward to seeing you on our future webinars. Thanks again, everyone.